excuse me.
No worries.
All right.
And if you want to make it a little bigger, you can just on the bottom hit the presentation slide next to like how you zoom in. Perfect.
Okay. All right. So I introduced myself earlier, but again, my name is Allison Sela. I'm the medical director of intensive care and cardiopulmonary services at Mon Health Preston Memorial Hospital. And today we're going to speak about the interpretation of pulmonary function tests. We're going to briefly go through the testing and talk about some of the differential diagnoses that you may want to think of when you see these pulmonary function tests. Again, we're going to discuss the different components of pulmonary function testing and the conditions that the results may indicate, and then what we use to interpret these tests. So I first wanted to start by talking about bronchodilator withholding times. And so generally when we send patients for pulmonary function testing, we do want to withhold their inhalers prior to testing if at all possible. And this is especially important with the first set of pulmonary function tests that you're getting on a patient. We would like to have a very clear picture of what's happening, and we don't want inhalers to be clouding the picture. So we want to make sure that we give the patients enough time to get these medications out of their system so that we can get a very clear picture of what is happening. And so for short-acting beta agonists such as albuterol or levalbuterol, we would want patients to hold those for about 4 to 6 hours prior to testing. For our short-acting muscarinic agents, such as Atrovent or ipratropium bromide, we'd want to hold those for 12 hours. And our long-acting medications, we'd want to hold for 24 hours. Some of our ultra-long-acting medications, which are the ones that patients are taking only once a day, should be held for 36 hours. And then our long-acting muscarinics, such as you see them listed there, tiotropium, umeclidinium. Those are the Incruz, the Spiriva, anything that patients, again, would only take once a day should be held for 36 to 48 hours. Now, ideally, we have patients hold the medications for this amount of time. But I always tell my patients, I would prefer that they take their medications if they need to take something rather than ending up in the emergency department with a flare-up of their asthma or their COPD or something like that. If at all possible, I tell them just to take their short-acting medications. If they have to withhold their medications for 36 hours, during that time, they can feel free to take their short-acting medications as needed, and then try to hold those for 4 to 6 hours prior to testing. If they forget or if they do have to take their medications, I tell them just to be honest with the respiratory therapist and say, hey, I messed up. I took my inhalers this morning because it's my routine. That way there's a notation made on the pulmonary function test so that myself as a interpreting physician can sort of take that into account or at least make a note of that. This is the general idea. I do have a more specific withholding time for specific medications that I'm happy to share if anybody is interested. So the first thing that we want to look at when we get a pulmonary function test for interpretation is the quality of the test. We want to make sure that these tests are both acceptable and reproducible. And even if a test is suboptimal, we still may be able to get some useful information from that test. For example, if a pulmonary function test is normal and they didn't meet standards, you can't get more normal than normal. So, that does still provide you with some useful information. So when you're looking to determine whether a test is acceptable, specifically an acceptable FVC or a forced vital capacity, is that you want to see a rapid increase of airflow at the start of exhalation. And you want to see that their complete exhalation requires at least 6 seconds of exhalation with a plateau in flow. When you're looking for reproducibility, you want the test to be able to be reproduced at least 3 times, and all 3 of those tests must have an FEV1 within 200 mLs of each other, and all 3 FVCs must also be within 200 mLs of each other. And this is something that's done prior to the test even getting to my hands. The respiratory therapist is evaluating that, is making sure that these qualities are met, and if they're not, there's a comment box that says patient did not meet ATS standards for acceptability or for reproducibility. And again, that gives me a lot of information about what has happened during the test and how we can interpret these results. And it doesn't necessarily mean that we just throw these results out. We could still get some information from the tests. We do use reference equations for our pulmonary function tests, and these reference equations are derived from normal or healthy subjects that are matched for age, race, sex, and height. And so each reference value should have an upper and a lower limit of normal. That's something that we've worked with at Preston Memorial. When I started there, they did not have the upper and the lower limit of normal. And so we were using a standard hard number that if the patient was above this, then it was this disease. If it was below this, then it was this disease. And so, that's fine, but in certain populations, you're going to over or underdiagnose lung disease. And so if at all possible, it's better to have a reference equation and to use a lower limit of normal in order to determine where the patient falls on that scale. For our spirometry, what we generally use is an ethnically appropriate NHANES, and this qualifies for patients ages 8 to 80. They did not do the study in patients younger than that or patients older than that. Most patients that we're getting pulmonary function tests on generally fall within that window. But again, there are different reference equations for different races. And so you do want to make sure that you're using the correct one. For lung volumes, there is no specific set of equations that is generally or universally recommended, but there are some equations for the total lung capacity, which is TLC, the FRC, which is the functional residual capacity, and the residual volume, the RV, that were recommended by the American Thoracic Society back in a 1995 combination paper from the American Thoracic Society and the European Respiratory Society. And then there was another workshop that was held in 1993, and they all sort of recommended the same equations. And so that's generally what we use, although we'll get into this a little bit further on in the presentation that there are some variations. And then also for the diffusion capacity, there's no specific set of equations recommended across the board, but these are the ones listed here are some of the ones that we do use. And so a lot of times you'll see either these equations listed, that this is the standards that they use, or some physicians will list them in their interpretation. So when we talk about spirometry, what we're looking at is the FEV1 over the FVC. And what this is it's the amount of air that's exhaled in 1 second compared to the full forced vital capacity. So the full amount of air that the patients are able to exhale. And the GOLD guidelines suggest using 0.7 as the cutoff. And like I said before, this does result in false positives in males that are over age 40 and females that are over age 50. So you're going to be diagnosing patients with COPD that may not have COPD. You're risking overdiagnosis, especially in elderly never smokers, because as we age, our lung function does decline, and so we start to see this number drop off. And if you use this solid value of 0.7, you're going to be overdiagnosing patients. So if you use the 5th percentile or the lower limit of normal, which is what is suggested by the American Thoracic Society, that is matched for this patient's age, race, height, and sex. And so you're going to find less overdiagnosis if you use this as your cutoff versus the 0.7. This diagram just shows, what spirometry is measuring. And so we're looking at the FEV1 versus the FVC. And this green line shows about an 80% FEV1 versus FEVC. So this is considered normal. The blue line shows an FEV1 to FVC ratio that is less than 80%. And so that's typically the type of line that we would see the time volume curve for patients with obstructive lung disease. And the orange line is an FEV1 FVC greater than 80%. And that's typically what we would see in patients with restrictive lung disease. So what we're looking at and what we've talked about so far, what we're looking at so far is we have sent the patient for spirometry. We've measured their FEV1 and their FVC, and it can fall into one of three categories. It can be normal, it can be low, or you can have a normal FEV1, FVC, but a low vital capacity. If patient spirometry is normal, you want to look to see, do their symptoms or clinical presentation suggest asthma? If they have a low FEV1, FVC, we're looking towards a diagnosis of obstructive lung disease. And if they have a normal ratio but a low vital capacity, we want to consider restrictive lung disease. So if you have a low FEV1, FVC, again, we're concerned about the possibility of obstructive lung disease. In that case, what you want to do is then look at the FEV1 in order to give it a degree of severity. And there's two different scales here. The top one is the gold scale of FEV1. And so in the gold scale, anything greater than or equal to 80 is considered a gold stage 1. Anything 50 to 79 is a gold stage 2. 30 to 49, gold stage 3. And less than 30 is gold stage 4. And when we give these a severity classification, usually we consider them mild, moderate, severe, and gold stage 4 is very severe. The table below is from the ATS standards, and the cutoffs here are slightly different, and they do have 5 categories instead of 4 categories. And on this, with this reference scale, they use mild as anything 70 or above, moderate is 60 to 69, moderately severe is 50 to 59, severe is 35 to 49, and then anything less than 35 is very severe. And so it does vary somewhat to give these patients a degree of severity for their obstructive lung disease. And so you may see, you know, if you have a patient with an FEV1 of 34, it would fit into 2 different categories. If you use the gold stage, they would be considered moderate, but if you use the ATS standards, they would be considered very severe. And so this can be confusing. And again, you know, it's important that we do identify, you know, which type of scale we're using when we interpret pulmonary function tests. If you have a normal ratio, but you have a low vital capacity, then we're concerned about restrictive lung disease. And so at that point, you would then go on to look at the lung volumes to further classify or clarify whether the patient does in fact have restrictive lung disease. And if the patient has a normal FEV1, FVC, these patients may be normal, but you can also see normal pulmonary function tests in patients with asthma. And so if symptoms suggest asthma, you may want to consider some type of bronchoprovocation testing. The most common one that we do is the methylcholine challenge test. This diagram shows flow volume loops and what they can look like in patients with obstructive lung disease. So you know, not just the numbers we're looking at, we also do want to pay attention to the flow volume loops. A is considered a normal flow volume loop. You've got the inspiratory loop is located below the solid black line, and the expiratory loop is above the solid black line. So A is considered normal. You can see on B that the loop below the black line is flattened. And this is the inspiratory loop, but it actually indicates an extrathoracic obstruction. You see the opposite in C where the upper loop is flattened, and this actually indicates an intrathoracic obstruction. D is a fixed obstruction where both loops are somewhat flattened. And then E is a peripheral or a lower airways obstruction. And you see a little bit of a scooped out pattern to the upper loop. So the first case, we have pulmonary function tests on the left, and the patient is a 65-year-old man. who undergoes pulmonary function testing as part of a routine health screening. He has no pulmonary complaints. He's a lifelong non-smoker and had a prior history of asbestos exposure while serving in the Navy. You can see his pulmonary function test here. So again, the first thing that we want to look at is the FEV1 FVC ratio, which is here in the third row down. And the actual number that he has is 80.95. And when we compare this to the lower limit of normal, which is 69.37, he is above that lower limit of normal. And so what we would say is that this is either normal or it could be restrictive. So then we would go up to look at the FVC, and the FVC is 86% of the predicted value. So this is a normal FVC. And so we can say that this patient has normal pulmonary function tests. And you can see down here at the bottom that his flow volume loop does look pretty normal. So this patient has normal pulmonary function tests. And that's basically what I just said. So the next thing we look at after we look at basic spirometry is we go on to look and see whether the patient responded to bronchodilators. And so in this instance, what we're going to look at is spirometry both before and after the administration of bronchodilators. And this helps us to determine if there's any reversibility of the patient's airflow obstruction. Generally, what we give is albuterol inhaler, which is a 90 microgram inhaler. And we give 4 puffs, and then we repeat the pulmonary function tests 10 to 15 minutes later. And so what we're looking at is to see if there is a response. And the way that we determine whether there's a response is we need to see both a 12% and a 200 cc or a 0.2 liter increase in either the FEV1 or the FVC from the patient's baseline. Now, you must have both the 12% and the 0.2 liter increase, but it can be in either the FEV1 or the FVC, but you've got to have both in whatever value you see the improvement in. If the patient's spirometry reverses back to normal after you give bronchodilators, this essentially rules out COPD. The difference between asthma and COPD is that asthma is reversible back to normal. COPD can be reversible. You can see an improvement after bronchodilators in patients with COPD, but it does not go back to normal. Now, some patients do note that their breathing feels better after they get bronchodilators, but there's not an appreciable change in FEV1 or FVC. And this may be due to several reasons. They may have an increased airflow within their tidal volume, but not during deep inhalation. And so that may be why we see a difference. If patients take a deep inhalation, there is some airway narrowing, and that may sort of offset this bronchodilator response that we're able to measure. And so don't rule out bronchodilators if the patient doesn't revert back to normal or doesn't have this great increase in their lung function after getting bronchodilators, because they still may see some benefits. And patients will generally tell you, you know, I take this inhaler and I feel much better after using their albuterol. So don't rule it out just because you don't see a huge improvement on pulmonary function tests. So case number 2, we have a 54-year-old female who presents to her primary care provider with dyspnea and cough. She's a non-smoker and has no relevant occupational exposures. And here you can see it's very difficult on this. You see the predicted is indicated by the dashed lines. The smaller or lower flow volume loop is her pre-bronchodilator loop. And then you can see the one that's taller is her post-bronchodilator flow volume loop. And so you can see that there is an improvement after bronchodilators. And this is her pulmonary function test. So you can see the FEV1 FVC ratio is 87%. You can see that her pre-bronchodilator FEV1 is 64% predicted. Her pre-bronchodilator FVC is 102% predicted. Post bronchodilator, her FVC went up by 1%, and it went up by 150 cc's from 4.05 in the first column to the, first column of numbers, to 4.2 in the fourth column of numbers. So that is not a 200 cc or a 0.2 liter increase. So you can say that the FVC did not show a significant bronchodilator response. However, when you look at the FEV1, you can see that the patient went up by, I believe this is 54%, but they went up from 3.53 to this number here, which is really blurry. And I think I have it on the next slide here. Maybe, what is happening? There we go. Went up to 64%. And so it's greater than a 12% increase. It's a 64% increase. And overall, they went up 1.43 liters. And so they did not, I'm going to switch back here again, did not have a bronchodilator response in the FVC, but they did have a bronchodilator response in the FEV1. And again, that is indicated by having both a 12% increase, this patient had a 64% increase, and a 0.2 liters increase in volume. And this patient had a 1.43 liter improvement in FEV1. So this patient did have a significant bronchodilator response on their pulmonary function test. And so they actually did reverse to normal. They went from a 64% FEV1 up to 104% FEV1. They reverted to normal. And so this patient would be diagnosed with asthma, most likely. Now, one other thing that I did not mention when we were talking strictly about spirometry is that when you stage these patients, like I showed the severity staging for obstruction, they really truly should be staged based on their post-bronchodilator FEV1. And so this patient would not be called a moderate obstructive disease with the FEV1 of 64%, but they would be called normal spirometry with a significant bronchodilator response. They really should be staged based on their post-bronchodilator FEV1 if available. I'm going to check the chat real quick. Dr. Doyle chatted in, shows gold and ATS by side by side, and then column 1 is predicted and not measured. Let me go back.
That was just on case 2, Allison. That comes up a lot. That we
it does. Yeah, that is a really good point. And so I'm sorry. Yes. You can see, I'm sorry, I'm going to go back through these pretty quickly here. You can see that in this first set of pulmonary function tests, our first column here is actual, and our second column is predicted. Our third column is lower limit of normal, and then percent predicted. And when we go to this next set of pulmonary function tests, which these are actually before we switched our machine at Preston, our first column here is predicted, and our second is our actual numbers. So yes, make sure that if you're looking at pulmonary function tests from your hospital, you know what order things are in, especially if you get a new machine, make sure you're paying attention to what order things are in. If you're looking at pulmonary function tests from an outside facility, again, make sure you're looking at what order you're in, because things can get somewhat confusing based on how each individual hospital has things set up. And in fact, in my hospital, our pulmonary function tests are set up differently for our general pulmonary function test versus our black lung pulmonary function test. So make sure that you are paying attention to how things are set up. Thank you, Dr. Doyle. That's a very good point. Okay, so moving on to lung volumes. Lung volumes are most important in, well, they're important across the board, but specifically when you're concerned about a restrictive lung disease, lung volumes become important because they really do help you to make that diagnosis. So again, when we're worried about restrictive lung disease, we have an FEV1 FVC ratio that is normal, but our vital capacity is low. And so based on that alone, you generally cannot say that this patient has a restrictive lung disease. You do need to confirm that diagnosis with your lung volumes. And so body plethysmography is our gold standard, but you can also perform this test using helium dilation or nitrogen washout. And I don't have enough time to get into all of those, and I can certainly do that at another time. But there's other ways that you can measure this as well. One way is by using a high resolution CT scan of the chest. And interestingly, this does correlate to within 15% of your body pleth results if the patient takes a maximal inspiration during CT scan. Helium dilution and nitrogen washout may underestimate patients' lung volume if they have moderate to severe COPD because they don't actually access these underventilated or non-ventilated areas. And so you may be underestimating their lung volumes. So the common lung volumes that we use are shown here on this diagram. Your vital capacity, which is abbreviated VC, is the maximum volume that can be exhaled after a maximum inspiration. And so that is, from your maximum inspiration all the way to your maximum exhalation. Your residual volume, your RV, is what is left over after that maximum exhalation. Your functional residual capacity, your FRC, is the volume of air that remains at the chest, in the chest after the end of a tidal volume breath, which is a normal breath that you take in and you take out. You're not trying to forcefully exhale anything. And your functional residual capacity is what's left over. Your expiratory reserve volume is the volume of air that's exhaled from your end tidal volume to your point of maximum exhalation. So if you're breathing along and you take your normal breath in, your normal breath out, your normal breath in, your normal breath out, and then if you take that normal breath out and then you forcefully exhale the rest of that, the difference between the end of that tidal volume breath and that extra that you're pushing out is your ERV, your expiratory reserve volume. Inspiratory capacity is the maximum inspiration from your end tidal volume to your total lung capacity. So this is the end of that breath, and then you're going to take a nice, end of a normal breath, and then you're going to take a nice big deep breath in. That is your inspiratory capacity, how much you can take in from the end of your normal breath. And then your total lung capacity is all of it, the volume of air in your lungs at the end of a maximum inspiration. And this is usually calculated by adding your residual volume plus your vital capacity, or your FRC plus your inspiratory capacity. And I really like this, this diagram here on this page. I think it really breaks it down so you can understand how these volumes are associated with each other and how they're calculated or measured. Excuse me. So when you're looking at restriction, you can use the vital capacity and the total lung capacity to confirm restrictive lung disease. Your vital capacity would be less than your lower limit of normal, which is roughly estimated at less than 80% of predicted. But again, as I mentioned before, a reduced vital capacity alone is not generally enough to diagnose restriction because there are other things that can cause a reduced vital capacity, such as air trapping due to severe obstruction. And so the diagram here on the left is for patients that are unable to get lung volumes for whatever reason. You don't offer that service in your office. They were unable to complete that testing. It just wasn't ordered by the outside provider. And so you can use your vital capacity to sort of determine whether the patient has restriction, but it's always better to confirm that with lung volumes. And so the degree that we use is their FVC below 80% of predicted? If not, this is a normal spirometry. If it's 60 to 80% of predicted, then you could call this a mild restriction. 50 to 60, a moderate, and below 50 would be indicative of a severe restriction. So if that's what you have, you certainly can use that, but keep in mind that if you have this patient who, worked in the coal mines and smoked 3 packs of cigarettes a day, this may not be an accurate representation because of air trapping. It may show up as a reduced FVC when it in fact is not a restrictive lung disease. So I mentioned at the beginning that we do not have any solid set of numbers that we use to determine how restricted a patient is. And so you can see here, there's 3 different charts and there's 3 different sets of numbers. Generally, what we use and what I was taught during fellowship is the one on the bottom. Your total lung capacity, 60 to 80% is considered mild restriction, 40 to 60 is considered moderate, and less than 40 is considered severe. The one on the top right, I pulled from, I can't remember where I pulled that from, but it's slightly different, and they use 65 to 80 as their cutoff for mild, 50 to 65 for moderate, and less than 50 is severe. And then the reference for the one on the left is there. And using total lung capacity, which is the first set of numbers, they actually are a little bit more severe. They use 70 to 80 as mild, 60 to 70 as moderate, and then less than 60 is considered severe. And so you can see there's not a real great consensus across the board as to what qualifies as mild, moderate, or severe. Generally, you know, again, I use the scale on the bottom because that's what I was taught in fellowship. But I tell patients that more importantly than, you know, is it mild, moderate, or severe, is the trend and which way it's going. And so as we repeat our lung volumes in 6 months or a year, is it getting better? Is it getting worse? And that's what we generally use to determine disease progression, is, you know, which direction they're going in. Okay. And so that's what we've been talking about is restriction. And so that's one use for our lung volumes. And generally we use the total lung capacity. We do use some other lung volumes to look at patients with obstructive lung disease. We also use the total lung capacity, but we also use the residual volume. So since we've been talking about the total lung capacity, we'll stick with this. So again, reduced total lung capacity is anything that's 80% or below, indicates some degree of restriction based on which schedule you're using, which scale you're using. Anything that's 80 to 120 is considered a normal lung capacity. But once you get above 120, then that indicates hyperinflation. So your total lung capacity is greater than what it should be. You've got some degree of hyperinflation. And we can see this in our asthma patients, but more often we see this in our COPD patients, that they're holding air behind, that they're able to overfill their lungs due to you know, wear and tear on the alveoli, that the elasticity is broken down and they're holding more air behind. We also look at the residual volume, the RV. And when that number is, and again, this is not a clear number either. Some say greater than 120, some say greater than 140. But when that number is elevated, it indicates air trapping, that there's air trap behind the lungs that's not fully exhaled. And so usually air trapping and hyperinflation go hand in hand. And it can be pretty high. I've seen patients with residual volume as high as 320% of predicted. And so those are, you know, those are your, you know, these little tiny COPD patients that have these great big lungs on chest x-ray that the radiologist has had to shoot 2 films in order to get their lungs from the apex, you know, to the diaphragm captured. And so we do tend to see that with our COPD patients. When you have a patient that has hyperinflation or air trapping, there are certain things that you can see on chest x-ray. And this is an example of some of those findings. And so you can see several things. The diaphragms appear flattened, so they're not nice and domed like they should be. They appear sort of flat. And you can see increased space between the ribs. And one of the other common findings that you can see on the lateral view is an increase in the space behind the sternum. And so you can see the sternum here is this solid white bone. And then behind that, you see this increase in this retrosternal space in front of the heart behind the sternum. Okay, so this is the flow diagram that we had looked at earlier. And you can see that when we're interpreting pulmonary function tests, we start with spirometry. We look at the FEV1 FVC ratio. We're looking to see whether it's low, indicating obstruction, whether it's normal, or whether it's normal with a low vital capacity. We've talked about normal with a low vital capacity is suggestive of restriction. We then confirm that with lung volumes. And then that leads us to our diffusion capacity. When we have patients with normal spirometry, if their symptoms suggest asthma, we would then want to go on and do a bronchoprovocation challenge, which again, I mentioned most generally is a methacholine challenge. And then based on the results of that, we can say, yes, this is asthma or this is not asthma. If the ratio is low, we're concerned about obstruction. We look to see whether patients responded to bronchodilators. If the patient did respond to a bronchodilator, we're concerned that this is most likely asthma, especially if they had a complete reversal. And then we move on to diffusion capacity to sort of determine a little bit more likely what the cause of any of these diseases are across the board. Okay, so before we do that, we will go on to case 3. And case 3 is a 60-year-old man who presents to his primary care physician with complaints of increasing dyspnea on exertion. He has a 40-pack-year history of smoking and is retired following a career as a building contractor. So, again, you want to look for clues in your question stem. So he smoked and he worked as a building contractor, which means that he's had exposure to all sorts of occupational dusts, including the possibility of asbestos. His pulmonary function testing is as follows. So we'll walk through this step by step. We're going to assume that this is a quality test that met ATS standards. And in the first set of columns, we have the pre-bronchodilator numbers. In the second set, we've got the post-bronchodilator numbers. The first column of numbers is our actual number, followed by our predicted, followed by our lower limit of normal, and then our percent predicted. The first thing we're going to look at is our FEV1 FVC ratio. And for this patient, it is 49.78. Again, if we were looking at the gold standard, we would look at that number. Is it greater or equal to 0.7 or 70? This is lower. When we look at this specific patient's lower limit of normal, his lower limit of normal is 70.25. So in this particular patient, there's not a big difference. Now, if this was an 80-year-old female, this lower limit of normal would be decreased. So this patient's FEV1 FVC ratio is 49.78, which is less than his lower limit of normal. So we would consider this obstructive. We then go up to look at the FEV1, and we see that the pre-bronchodilator FEV1 is 39% predicted. Now, if we did not have the second set of numbers, we would determine what his degree of obstruction is based on this 39% of predicted. We do have a second set of numbers. So like I said, we should be monitoring and diagnosing the degree of obstruction based on the post-bronchodilator FEV1, which is 53% predicted. And so we've got a moderate obstruction. Next, we look to see whether this patient had a significant bronchodilator response. And so what I tell the residents when they work with me is that, the quick and dirty way to determine whether a patient has a bronchodilator response is to go over and look at this last column of numbers. You're looking at the FVC and you're looking at the FEV1. So these top two numbers, is one or either of them 12% or above? If it's not, you can stop right there and say this patient did not have a bronchodilator response. But you can see in this patient that he did have a greater than 12% response in both. He had a 28% response in his FVC and a 35% response in his FEV1. So then what you want to do is go back and make sure he met the 12% criteria. Did he meet the 200 cc's or the 0.2 liter criteria? And if you go and look, he did. He went from 1.4 in the FEV1 up to 1.9. So he actually had a 500 cc or a 0.5 liter improvement in his bronchodilators. So you would say that this patient has moderate obstructive ventilatory impairment with a significant improvement. Then you're going to go down and look at the lung volumes. And the lung volumes that we want to look at are total lung capacity, our TLC, which is the third row from the bottom. And you want to look at the percent predicted, which is 117% predicted. So this is normal. It's less than 120, but greater than 80. The residual volume, the line just above that, is 280% predicted. So this patient does have air trapping. So you would call this patient a moderate obstructive ventilatory impairment with a significant bronchodilator response. Lung volumes show air trapping. And so if you look over here at this flow volume loop, it looks very similar to the one that we saw in the diagrams on the end. You can see the dots indicate the predicted values for this patient. And so you can see that his predicted values are much less than where they should be. This lower flow volume loop, the shorter one, is his pre-bronchodilator. The taller one is the post-bronchodilator. And so you can see that there was an improvement after we gave the bronchodilators. It did not go back to normal. And so this patient would be considered to have COPD. And again, this just summarizes what I talked about. We've got a moderate obstructive ventilatory impairment with a significant bronchodilator response, but the patient did not reverse back to normal. Now, that does not mean that this patient does not respond from bronchodilators. In fact, we saw that he did. He had a half a liter response in his FEV1. So he did respond, but did not get back to normal. And that's where we diagnosed this patient with COPD versus asthma. And then the lung volumes showed an increased residual volume or air trapping. I'm going to check the chats real quick. So Dr. Doyle asked, case 3, lung volumes before or after bronchodilators. So the respiratory therapist can correct me, but generally the way that we do the pulmonary function tests, if I can get this to go back, is that we do the spirometry, the lung volumes, the diffusion capacity, then we give the bronchodilators, and then we repeat the spirometry. So we generally do not do the lung volumes and the diffusion capacity post bronchodilator. And his question was, would you expect the lung volumes to be improved following bronchodilator? And I would say you probably would, because what the bronchodilators do is they help to relax the smooth muscle, they help to open and dilate the airways. And so by doing that, the patients would likely be able to exhale a little bit further and get some of that residual air, that trapped air out of their lungs. And so you may see an improvement in lung volumes post bronchodilator. But I don't know that I've ever seen post bronchodilator lung volumes reported in any pulmonary function tests.
Actually, I was asking that because of the huge residual volume and the huge post-bronchodilator improvement in spirometry. So I was thinking that I might expect to see that. I understand that's not the normal technique, but I just want to make sure that.
So if you think about residual volume is the amount of air that's left behind after that forceful expiration. And so residual volume probably would not change, but total lung capacity may change. Well, and if your total lung capacity changed, then your residual volume would change. So they may, I would say they probably would at least a little bit, but probably not a lot.
Great, thanks.
All right, so we'll move on here to diffusion capacity. And what diffusion capacity is, it's the measure of the conductance of gas transfer from inspired gas to the red blood cells. And so, if you remember that your red blood cells are carrying your oxygen molecules. And so the red blood cells do play a large part in how much oxygen you're going to carry and how much carbon dioxide you can remove. And so if you have a patient who has any type of alteration in any of these oxygen carrying components, we should make sure that we're adjusting for that. And specifically, if you have a patient with anemia, you may find that their diffusion capacity is lower than what would be expected. If you have a patient who is a cigarette smoker, their carboxyhemoglobin levels would be higher. And so this would displace their normal transfer. And so you would expect their diffusion capacity to be lower. High altitude also should be adjusted for. And then there should be a volume correction also made based on the areas of the lungs that are not participating in gas diffusion. And this is especially important in patients that have large blebs or bulla in their lungs. And you generally do see this reported at the bottom of your pulmonary function tests. But what you need to be careful for is sometimes they will report a diffusion capacity that's adjusted, quote unquote, for the patient's hemoglobin level, but they don't have an up-to-date hemoglobin level, or they haven't put any hemoglobin level in. And so, that's something to keep in mind too. If the hemoglobin level they used was from 3 years ago when the patient was, in the hospital for a GI bleed, then that's definitely going to alter and not be accurate for this. So you want to make sure, did they put a hemoglobin level in, number one, and is it an up-to-date hemoglobin level? So when you look at diffusion capacity in patients with restrictive lung disease, it helps you to distinguish between some type of intrinsic lung disease in which you would see the diffusion capacity is reduced versus other causes of restriction in which the diffusion capacity is generally normal. So the intrinsic lung diseases which we think about is something like pulmonary fibrosis or progressive massive fibrosis that we would see in our co-workers. And in these patients, your diffusion capacity is reduced because they have areas of lung that are not participating in gas exchange versus other causes of restriction in which the diffusion capacity would be normal. And so this would be scoliosis or pregnancy or a patient with large breasts that are pushing down on the chest and causing restriction, but in which the gas transfer is not altered. And so the diffusion capacity would be normal for those folks. When you look at diffusion capacity in patients with obstructive lung disease, it can help you to distinguish between emphysema and other causes of chronic airway obstruction like asthma. And then when you have a patient with normal spirometry, but a decreased diffusion capacity, you want to keep in mind pulmonary vascular disease, such as chronic thromboembolic disease, where they continuously have multiple pulmonary emboli or pulmonary hypertension. And with both of those, you can see a decrease in your diffusion capacity with normal spirometry. This is the general interpretation and the scale that we use for diffusion capacity. And this was obtained from UpToDate just for a reference. Normal is a percent predicted of 76 to 140. Anything greater than 140 would be considered an increased diffusion capacity. And then below 76 would be considered decreased diffusion capacity. 60 to 75 is mild, 40 to 60 is moderate, and then severe is less than 40. And I don't go on to talk about what would cause a high diffusion capacity, I don't believe. But keep in mind, one of the big things that we see is anything that's going to increase your ability to transfer oxygen for carbon dioxide. And so one of the big things we see, although we're not necessarily doing pulmonary functions on these patients, would be patients that come into the ICU with pulmonary hemorrhage, where they've got blood in their lungs. So they've got this excess blood in their lungs, so they're able to exchange more oxygen for carbon dioxide. We also do see an increased diffusion capacity in our asthma patients. And so those would be the general times that we would see this number being elevated. And sometimes, they have otherwise normal pulmonary function tests, but they'll have this increased diffusion capacity. And so sometimes that sort of hints at that and maybe another reason to send them for bronchoprovocation testing. Low diffusion capacity can be seen in cigarette smokers. So if I have two patients, same age, height, sex, race, and I send them both for pulmonary function tests, I generally expect the smoker to have a lower diffusion capacity than the non-smoker. If a patient quits smoking, this does go back to normal. And so that indicates that this is not all due to some sort of emphysema that this patient has developed with their history of smoking, that this does revert back to normal if the patient quits smoking. And our patients with obstruction, if you've got a long-term smoker, it usually is due to emphysema, although again, there is some additional decrease related to their continued smoking. The loss of diffusion capacity usually occurs after the decline in FEV1. So we usually see the FEV1 decline first. If you see a decreased diffusion capacity in children or young adults, you do want to consider cystic fibrosis or alpha-1 antitrypsin deficiency in these patients. Also, some other diseases that show obstruction on pulmonary function tests would be bronchiolitis obliterans, bronchiectasis, and lymphangiomyomatosis. And again, this is, these patients have some sort of general intrinsic process too that is causing them to not be able to exchange oxygen and carbon dioxide as well. Again, in restriction, we want to think interstitial lung disease or some type of pneumonitis, some type of process in the lungs that is not allowing this gas exchange process to occur. And then in normal spirometry, we talked about pulmonary vascular disease or even early interstitial lung disease. You may have normal pulmonary function, but a decrease in diffusion capacity. So if you've got a patient who's on amiodarone, who is the typical person that I would see this on, is that they've got normal spirometry, but they start to lose their diffusion capacity, and they start to get a cough, and the only thing we're seeing is that their diffusion capacity is going down. Keep in mind, that this may be an indication of an early interstitial lung disease developing. And so if there's risk factors that you can modify, such as stopping the amiodarone, or getting out of a work environment that may lead to some interstitial lung disease, that would be the time to try and do that for your patients. So in general, things that are going to decrease the surface area of the alveoli are going to decrease your diffusion capacity. So, if you have emphysema, if you have something that's breaking down the surface area or obstructing that, or changing the interstitium of the lung so that you don't have that surface area to perform this gas exchange, you're going to see your diffusion capacity decrease. So we've got case 4. We have an 81-year-old female with a cough. And so we'll go through this step by step. And again, the first thing we want to look at is our spirometry, our FEV1 versus our FVC. And in this patient, I don't know how to get this. I don't know if you guys can see this. I've got like the menu across the top and I can't really see, but I think the first column is actual and this third column is lower limit of normal. So their FEV1 FVC is 77.97. Their lower limit is 62.07. And so they're above their normal limit. So their spirometry is either normal or it could suggest restriction. And so when we look at the percent predicted of the FVC, it's 71% predicted, which is on the lower side. Again, quick and dirty for post-bronchodilator. You look at the FEV1 and the FVC, neither of these show a 12% improvement. And so you can say that there's no bronchodilator response. You don't even have to worry about looking at the raw numbers. When we go down to look at our lung volumes to see whether this is a normal spirometry or whether it does in fact confirm our suspicion of restriction, we look at our total lung capacity, and it is 64% predicted. And so that does fall into mild restriction. 60 to 80 would be mild restriction.
Dr. Sela?
Yes.
I hate to cut you off, I really do, but in the interest of time, we have a minute left.
Okay.
And so we'll probably have to end there. We can always
let me finish this slide.
Okay.
And because I do want to get through the diffusion capacity here. So we've got some mild restriction. And then when we go down to the diffusion capacity, you can see that this patient's diffusion capacity is 27% predicted. And so this is a severely decreased diffusion. This is a patient who was on amiodarone, and I'm happy to say that her most recent pulmonary function test did show that her diffusion capacity after stopping amiodarone is improving. So we do see an improvement with decreasing that. And then this is a slide that shows what causes increased diffusion capacity other than the things that I talked about. Just in another way, this is the flow diagram, which goes on and just tells you a little bit more about what the DLC means in relation to these diagnoses. And then there's just a couple more cases at the end, and then my references. So I'm happy to send this presentation out. And if you do have any questions about any of these cases at the end as you work through them yourself, you can just let me know.
Thank you so much, Dr. Sela. That was really great. And I really do like the cases that are intertwined inside of there. So that's really, really helpful. I will make sure that we do put that out there and we'll get that in the recap as well. Yeah, we'll do this as an annual discussion too. So this is really great. Thank you so much. And just a quick announcement, our next session will be March 21st with Dr. Doyle, and he's going to be discussing differential diagnosis of acute exacerbation. So look forward to that. Thank you so much and have a great rest of your week, everyone.
Thank you, everyone.